I'm Ruth, and I'm one of the IIPDW board members. I work as a mental health researcher at King's College London. And this segment of the conference, we're going to talk about managing withdrawal projects in the UK from the 1980s onwards. And we've got three brilliant speakers. We're going to talk about the services they've worked on. So we've got Jayne Lovell, who's worked for the Welsh Health Board for 43 years and runs the Prescribed Medication Support Service in Wales, which is an award-winning service, and it's just won a British Empire Medal, and it's been running for 30 years. So thank you, Jayne. And then we've got Melanie Davies, who has worked as the manager of the REST service for 30 years. This is a benzodiazepine project serving Camden and Islington. She's also an expert advisor to the IIPPGDD, member of the Council for Evidence-Based Psychiatry and co-group facilitator to a deprescribing clinic in the NHS in England. And then we've got Jayne Hoyle, who worked as the manager of the Bristol and District Tranquilizer Project for the past 13 years, which supports people to withdraw from benzodiazepines and other psychiatric drugs. And before that, Jayne worked as a psychologist in the NHS. Okay, so we're first just going to talk a bit about the projects that you've managed or run. So Jayne, do you want to go first?
Yeah, thank you very much. So thank you, Ruth, and thank you everybody for inviting me to speak at this conference today. So as Ruth said, I'm a trained psychiatric nurse. I also trained as a counsellor and a supervisor, and I've worked for the National Health Service for 43 years. I cannot believe it, a blink of an eye. And since 1995, I've managed the Prescribed Medication Support Service. This service is a unique service in that, as far as I know, it is the only health board run service in the UK, and we're working with the all-party parliamentary group in drug dependency, with Anne to support the formulation of a national service, possibly using a similar model, although it may eventually look like something different. Currently, the service that operates in North Wales has an open caseload of about 250 clients. And we support the reduction of a range of prescribed medications, such as minor tranquilizers, antidepressants, painkillers. There was a question on the chat before about antipsychotics. We do support people to reduce antipsychotics because we're embedded within the health board. We will work alongside psychiatrists, alongside GPs. So it's a triad service in a way that we support the reduction, but we work with the GPs and the psychiatrists for the starting.
Oh, hi Lucy, what a disaster. It's saying the video's turned off now, so I mean I am here for the the vocals, but
Melanie, can you mute? We can hear you.
Yeah, hold on.
Okay, so we work with any dependency forming medication that is prescribed within the British National Formulary Guidelines. So if they're taking in excess of that, then they might go to the Substance Misuse Service and we would refer over. So we're just working within the prescribed guidelines alongside pharmacists, GPs, consultant psychiatrists, substance misuse services, elderly teams. So we work right across. So just to go back, because one of the questions that Lucy was asking was, how did we set this up? So one of the pivotal points in my career was I was working for the Substance Misuse Service, supporting people to reduce their medication, and we had a lot of people coming forward wanting help to reduce their benzodiazepines, their antidepressants, their painkillers, and there wasn't a service there. And we did some very good work, and I must admit, we learned an awful lot from our clients at that time, and we found a way to slowly reduce and what additional social prescribing that was needed. We did quite a lot of preventative work, working alongside GPs. So we started to learn our craft back in 1985, and we recognised that there was a need for this prescribed medication service, but we were told at that time to work more within substance misuse. And that's why I approached a manager of our health promotion unit to look to see if we could do a research project. And the Welsh Government supported a research grant for a year. And so what I did was I worked within 3 different GP surgeries and piloted how a service might look. And then we monitored that and reported on that. We also tried to raise awareness by setting up interest groups with professionals and with clients as well. I ran a conference for all the GPs in North Wales, run by the late Professor Malcolm Lader, who was an eminent researcher in his field. And that was pivotal to encourage the Health Board to take on and set the service up in 1995. So this funded service was myself as one nurse specialist covering North Wales, and I was providing psychoeducation, I was providing reducing regimes, doing sleep hygiene work. But what became apparent very quickly was that I also needed the support of a counselling team to look at, as we've been talking before, that it's about the emotional and the behavioural change as well. It's a whole holistic approach. It's not just about reducing medication, but working with people to find out what they've tried before, what hasn't worked, what has worked. So it was all very much individualized, and that's something that we're very proud of in this team, that we work and we listen to each individual person and everybody we work with. How we work with them is different, and it is about their history, what they've tried already and what they want to do. So we set up to get some students to work with us, and I started off with 8 students, and I got a small amount of funding for that. And over the 30 years, we've probably trained over 500 counsellors to work in this field. So the counselling service is now a group of paid counsellors, but we've also got a network of qualified sessional counsellors. So these are some of the students that are staying with us, and we're managing to pay them a small amount of money to keep that quality in our service. And so on the counselling side, we've probably got about 300 clients a week. We've got a great relationship with all the universities and the colleges in our area who place their trust in us to provide a robust placement opportunity for the student counsellors. So that's how we've managed to expand our service, by enhancing it, by using the student population and by training them, and then so they're getting a trainee placement, but we're getting more counselling out there to the people who really need it. The prescribed medication service has gradually expanded through a number of funding streams. So we had some money from the Slips, Trips and Falls, which is the pharmacy initiative. And we also had some funding from the Substance Misuse Planning Board, as well as the Health Board. And so we now have 7 specialists that work across North Wales, which is a population of just under 700,000. So for every 100,000, we've got 1 specialist, just to give you some idea. So we're still very small as a team. We've also got 2 administrators working in the background, doing a phenomenal job and putting together, you know, all the feedback we do and all our monitoring reports. So we are monitoring ourselves and looking at growing and changing all the time. We've got 5 paid counsellors working with us now, 30 sessionals and 30 students. So that's what we look like. We get a lot of support from specialists from the pharmacy team. We've also set up a dependency forming rationalisation group, I didn't name that group. It is a multidisciplinary team which meets monthly, and this enables us to work safely with a range of complex clients. So in that multidisciplinary group, there is consultant psychiatrists, pharmacy, people from the pain team, and our specialists. We also have GPs who come in regularly to that meeting support as well. So it's a fantastic resource for us. We receive referrals from clients themselves, but we mainly receive referrals from GPs, and we work alongside them to support the clients to reduce, and there is an open dialogue of suggested teams going into the doctors. So we've got a healthy working relationship. We also get referrals from mental health teams, substance misuse. So we work with adults of any age. We then assess what the needs of the client is, but we're very much also a client advocate. So it might be that we also want to support a client maybe to stay on medication, have some counselling, maybe, and then go back, maybe do a reducing regime. So we're not just about taking clients off, and we're very much about prevention, so we're working in the GP surgeries as well. So the team has continued to grow. We develop and learn from our clients continually. I agree with what Anne said earlier on about trying to set up a dedicated helpline to this client group to make access easier at the point of need would be absolutely fantastic. So I think I've hopefully given you a good overview, and you know, I'm happy to take questions after my colleagues have spoken, but I hope that gives you a well-rounded feel for what we've been trying to do in North Wales. Thank you very much.
That's brilliant. Thank you, June. Okay, so next, Jayne.
Thank you, Ruth, and thank you for inviting me. It's fantastic to be here. I am reading off a script, so do forgive me if I keep looking down. So I was the manager of the Bristol and District Tranquilizer Project. The charity had been successful supporting people coming off prescribed psychotropic medications, and it was the only national helpline in the UK until its recent closure. Our services supporting clients ended on the 30th of September this year, and my role as the manager ended yesterday. So the charity is now sadly closed due to the loss of our NHS funding contract. So to talk about the history of the charity and how it all began and became the charity that gave hope and support to thousands of people for almost 40 years, started in 1984. With a housewife, Valerie Stevens, who was prescribed benzodiazepines and had made several attempts to stop taking her medication, but found that this was a struggle. She felt alone, isolated in this journey, and she thought that she couldn't be the only person that found it difficult to come off this type of medication. So she put an ad in the newspapers for anyone who might be facing similar issues. This was with the idea that perhaps they could support each other, and the ad included a local cafe to meet in on a particular date. In that first meeting in the cafe, a few people turned up, and through chatting and voicing their experiences, they found a common ground and a solid support system. And with a short period of time, it became evident that the meeting in the cafe was not sustainable as the group grew exponentially week on week through word of mouth. It was at these early meetings that Valerie met Una Corbett, and together they had a vision to set up a more formal support group, as it became apparent that they needed to expand and offer more help and support, as so many seemed to be affected excuse me, by involuntary addiction to benzodiazepines. They were offered a free space to use it for their group at the Bristol Drugs Project. And with any new initiative, you know, there were teething problems. Being a drugs project was one, and it was back in the 80s. So this was in a dodgy part of Bristol. It was very intimidating part of town. So they soon found that people just stopped coming to the group. At this point, there were also clashes between Valerie and Una, who had very different core beliefs in how they could create and expand. And Valerie was adamant that support provided was to be offered to people who were on a prescription of benzodiazepines. And Una wanted to support anyone who was taking a benzodiazepine, regardless of whether this had been prescribed. So at that point, the group split into two different support groups. So with Valerie remaining focused on iatrogenic harm from prescribed psychotropic medications. At this point, they found an alternative space for people to meet. And at that time, Ian Singleton started to attend the groups. And it was himself and Valerie who built up the charity, which became the Bristol and District Tranquilizer Project over the decades to come. In 1995, they received central government funding and became a registered charity in 1996. In 1998, the charity received its funding through the NHS up until its closure yesterday. Our patron for the charity was Professor Heather Ashton. She was of enormous help in setting up the charity in those early days. And the Bristol Tranquilizer Project's primary focus was to support people on a prescription of benzodiazepines, as I've said. But over time, this expanded to the Z drugs. It then became apparent there were similar issues with antidepressants. So again, the charity expanded to support, to include those. And since then, we've also helped people taper from antipsychotics and gabapentoids. So over time, using client feedback and consultations with Heather, we updated the manual with regards to tapering amounts and timeframes and added information for all the other medications we supported. The philosophy of the charity was that withdrawal from any psychotropic medication should be safe and gradual. At the centre was the client. We supported clients to withdraw, but we did not dictate. It was their withdrawal. We've helped thousands of clients to withdraw successfully over the years. The overwhelming majority did not have serious mental health problems, were not alcoholics, were not addictive personalities, but on these medications for primarily anxiety and depression. They were mainly ordinary people who were put under intolerable stress through a life event such as severe illness, loss of a job or partner that they were overwhelmed by. The problem then became medicalised rather than normalised, and prescriptions were then given rather than referrals for counselling and other non-drug therapies. Our success rate was around 90%. All of those we helped eventually came off their medications, all made reductions where there was a significant improvement to well-being. We offered a national helpline and took calls from all over the UK. In addition, we offered local face-to-face services, which included one-to-ones, groups, crisis management, and drop-ins. We offered support to family and friends also and provided advocacy. We also had an additional service dedicated to helping older adults. We've been very proud of all of our achievements over the years, our campaigning for recognition, and have all dedicated our working lives to giving a voice to those who are not heard, in the hope that harms caused by these medications are seen as such. We are deeply saddened by the loss of our charity, and for all those who used us as a lifeline, our service made a difference. Thank you.
Okay, thank you so much. It's really, really good to hear about your service. And okay. Melanie, if you want to go next. Good, but you got the camera working. Oh, you just need to unmute.
Good afternoon, everyone. I hope you're doing well. Sorry about the technological problems earlier on. I just wanted to say sincere condolences from the REST project to the Bristol Tranquilizer Project, and all the more heart-rending hearing your story over the years. That is so we've so duplicated in so many ways, and can say that your model of working is the one that we completely subscribe to, and I can absolutely not understand the decision that was made. And I'm still hoping that there's some way we can get the show back on the road for you. I know that's talking a lot about yours and not REST, but I do really think, as we're talking about the history of services of this kind, I think this shows already that these kind of services are not supported in the way that they should be. They don't have parity with a lot of other issues, because if they did, a wonderful service like that would not have shut. There's no justice. Also, the rest service serves the boroughs of Camden and Islington. So if I do have any inquiries outside those boroughs, it was wonderful to be able to put them over to the Bristol Tranquilizer Project, which I actually spoke at their AGM 2 years running. And, we just always had links over the years. Now, anything I'm going to say about rest is going to be so similar to what you've said. And I think that would indicate, as you probably know, I don't know, people that are joining us outside of the UK, but certainly within the NHS and the way the system runs, that there's a lot of crossovers to the difficulties we faced, the challenges, also the positives and what people were reporting. And obviously, we're in London, so you'd think there would be kind of differences, but it does go to show how prominent the drugs are on people's lives. It is about the drugs, like, primarily. But concerning rest started in 1988 at Mind in Camden, and I came into service in the early 90s. And at that time, obviously it was a much smaller project than it's become, but it's still tiny in terms of the staffing, but its reach has been tremendous into what I've been able to get involved in and how I've been able to represent members' views, ideas, get changing guidelines. And in fact, Jayne, that guideline that you mentioned with the BNF, that was a wonderful initiative that you got together, and then the different charities wrote, and Professor Ashton put that into a medical manner in a way that could be changed. And I think up to that point, that was probably I would say that was one of the biggest successes I had. And I couldn't imagine at that time, from a small project, that I would be able to influence something like that. And it just goes to show the power of the mutual aid, the power of collaboration. And after that, that gave me the confidence to get involved, as I have been on 2 NICE committees, on the IIPDW, on LEAP, all the other things I've done subsequently, because at one time, because we're not medical, we felt a little bit sidelined to have an influence on the conversation. But getting that, I really got my thinking cap on as to, well, how can we get around that? Because like you, I also met Professor Lader. I also had the honour to meet Professor Ashton. And when Professor Lader came to the project, he was saying we could do research. We'd need a trial group against the results that you're getting. But it would have involved about 100 members that were not accessing a tranquilizer group, that were on benzodiazepines, and that would have been an amazing, a massive organisation within borough, which we couldn't sort of get GPs on board for. But, he was able to see, as obviously he saw when he spoke to you, that our approach does have a fantastic results. And, we also had the 90% success rate for tapering, like reduction, and in some cases, obviously, total withdrawal. And our approach was completely user-led, like yours, that we didn't pressurize anyone to come off. We encouraged a withdrawal, offering 2 groups a week. And obviously a very important part of what I do is advocating for people with their GP, usually not to be taken off suddenly, but quite often for a slower taper plan. I could do that either going in with somebody or a letter. Getting a bit nearer up to the present day, I just feel there's so much for the project, and I don't feel I feel so bad that I can't do it justice. All the wonderful people that have been involved in the years. I don't want to name drop, but I just want to put in that we had people coming to do volunteer work when they were younger, like a psychologist, the different areas they were in at the time, and have gone on to massively fantastic endeavours. One of those was James Davis. He's now Dr. James Davis, that's a lecturer and has written 2 books. We've had another 2 psychologists, Scott and Mark, who are fabulous. And also we had Georgia, who came from the Project Reconnection in Australia. So it's all this richness. Plus I was situated in an office with members from the Hearing Voices team at Mind in Camden. So that was another mental health initiative. which was different than the work I'm primarily involved with, but it was just so progressive, and we were always in that ferment of user-led and ideas. And getting up more to the present day, we lost our funding, very similar to yours, Jayne, but we were recommissioned into Change, Grow, Live. So I've got Kate Dallas, my manager, and Rob Cathrew to thank for that they've made a kind of niche opportunity for the project to be in a drug and alcohol project, but with very distinct features. And of course, we did over the years always see people also that took illicitly, not necessarily as prescribed, because that could happen if somebody's prescription was cut. You know, they felt forced to kind of acquire through other means. So there was always a little bit of a crossover. So we do currently have people mainly who take as prescribed, and all the difficulties that attach with that, as we're all aware. But we also have some people who take illicitly, and we don't, you know, stigmatize that. Whatever your pathway into being dependent on this medication, we do all in our power to help. And just to add that, you know, I've seen thousands of people come off this medication. It is possible. It's difficult, but it is not impossible. And the range of people we've had has ranged from age of 18. Our oldest client will be 90 next year. So thank you so much.
Okay, thanks so much, Melanie. Okay, so the next section, we were just going to talk about challenges that you've encountered when running your services. So I don't know, June, if you want to start.
Hi, Ruth.
Hi.
Hi. There's always lots of challenges, and it's around the funding is one big thing, and getting funded and continue funding, getting the training and education out there. There's all sorts of challenges for us, all the connections that we make, and to change sensitively to the need of the client group out there, which is continually changing. And so we're learning and just growing all the time. So we are trying to work in a more preventative way, which was one of the things that was said there. So we're trying to work closer with the GPs in practice, so that they have the opportunity to say, well, maybe, you know, you can go and work with somebody around insomnia or sleep hygiene work, rather than having medication first, and those sorts of things. And also maybe trying to run groups as well, so that we can offer additional support. But it's all about manpower and how we move forward with that. But we are continually trying to learn from, you know, the client group that we work with.
Okay, great, thank you. And Jayne, do you want to talk about some challenges?
Okay, thank you, Ruth. I am going to be talking about the challenges we've had from the NHS and the funding of our contract. And just for clarity, what I'm talking about is from my own experience, and it is my opinion of what I have faced on the ground level. And with reference to the NHS and the funders, this is not the NHS as a whole, it's my direct link to the NHS in my locality in Bristol. So as I'd stated earlier, in the history of the project, we've been funded for decades by the NHS. And over the years, there have been many different funding bodies, and they've changed. But the conversations have remained exactly the same, with no insight from those in power to change any narrative. Throughout the duration of our service, we've had to fight for recognition. We've had to repeatedly explain that the field we work in is not addiction. It's not predominantly mental health. And sadly, there continues to be little insight from the harms caused that these medications and withdrawal symptoms experienced when trying to come off them. The result of that and the lack of education is that the service we provided had been a reactive one, where patients are put on these medications without warnings that they might find it difficult to come off. There are no reviews of medications, and consequently people are left on them for years. And because many prescribers don't recognise withdrawal, success in coming off is limited. And by the time people came to us, so much more harm had been done and other medications had been added. So one of the main challenges working under the NHS in my locality was the lack of communication, making connections and feeling part of. We were definitely always on the outside looking in. And our voice in the NHS was through what was called an assigned link officer. So we would liaise with the link officer, and they would then liaise with those who made the decisions around our service provision and the levels of funding we'd receive. So over the years, we've had a few great link officers, and the difference this made was always refreshing and gave us a sense of hope and optimism for change. However, the bad and indifferent ones did outweigh the good. Also, our link officers would change so often every couple of years. It was impossible to make any significant strides forwards. And we had to start conversations from scratch, which always began with, why aren't we a drug addiction service? How are we supporting underlying mental health issues? Why don't we refer clients to counselling? And asked if people have suicidal thoughts, why are we taking them off medication? Surely they should be on something else if what they're on isn't working. There was also constant inappropriate terminology repeatedly, for example, referring to clients as addicts, using words like drug misuse, relapsing, and how often we had repeat users of the services. And even the outcome measures we were told we had to collate weren't really helpful or informative to us. So in 2022, the NHS funding body changed again, and with that came the overhaul of mental health services, and all NHS contracts were being reviewed. During this time, which took under a year, our link officer changed 3 times. And this is the person that is the voice of our charity to those who are the decision makers. How can they explain the value of our service if they don't know the value? How can they convince a new funding body that what we do is greatly needed? None of these link officers had any knowledgeable understanding of our mission. And I do wonder if we'd had a good long-term link officer at the time, would things have been different? And I also question why I can't be directly involved with the decision makers to make my case of the service we provided to the community. The decision made in this review was to close the charity, and the reason they gave was that there was a duplicate service, which was in fact a drug and alcohol service. The decision went to an appeal, and I must admit I was hopeful at this point, as we collated a lot of evidence and support to continue a much needed service. I also thought the NICE guidelines and commissioning framework indicating that the NHS needs to provide services in this area would be to our advantage. However, they didn't know about these, and they didn't appear to take these guidelines into any consideration. With the decision standing to close the charity, the funders did identify another alternative provider that they determined was a duplicate, and that they would support our clients to transition over. Again, this wasn't a duplicate service. We were the only national helpline. There was no collaboration to transition. There was no support to access the service. Clients were given a contact number. Many of our clients would not be eligible to get support from the other service, and the NHS funders knew this. Their response was that people prescribed these medications after we closed can also be supported by their GPs. And I think everyone here knows that that sadly is not always the case. In my opinion, this was an extremely short-sighted decision and a recipe for disaster. I cannot fathom why, after decades, we seem to be in the same place fighting for recognition. In the fight for our charity to continue its much-needed work, my voice was not heard, just as our clients' voices were not heard. I was left with no option but to say goodbye to my clients, to unplug the phones and turn off the lights. There would be no more calls, no more support, no continued reassurance, and no one to talk to who gets it, who completely understands, and very little hope. Thank you.
Thank you, Jayne. And it's so sad that they decided to not continue the funding. Okay, well, thank you for that. And Melanie, do you want to talk about some of the challenges you encounter?
Yes, again, Jayne, I'm so sorry once again to hear that. It does, even if I hadn't had a similar experience, I would find that very traumatic and heart-rending, and it's so similar to what Rest was going through. We did fight another day, but it's all too familiar. I'm so sorry, and I've still got hopes that something could happen, and if there's anything we can do to help that, please do try and turn to us. The challenges, I would say, again, we're going to get that crossover. It's going to just sound like I'm copying the others, and it's not, because it is so similar, regardless of where we are across the UK. And that is that the funding is never guaranteed with commissioners. We always optimistically hope it will be, but it's not a guarantee. And what I'd love to see is that this would be on a similar parity with mental health, drugs, alcohol, that is much needed, ring-fenced, niche for prescribed harm. And we're not quite there yet. And as we all know, we're in campaigning groups and policy making groups to try and achieve that. So I would say the biggest challenge is all the wonderful, exciting, innovative work that's coming out in that area, but then what we're actually seeing. So it's impossible to really imagine, isn't it, that someone can be on a panel at that kind of level as Jayne is, and then her own service that she's running is be shut. So that tells you everything you need to know. But in terms of doing this work in Camden, in terms of Rest, I would say one of the biggest challenges is for prescribers and people in general to understand that obviously the benzodiazepine shouldn't be prescribed more than a few weeks, and that you would like social interventions instead of a dependency developing. But at the same time, once that dependence has developed, it has to be managed in a very nuanced way. So the tablets still need to be prescribed so that the person can be brought down on a hyperbolic, slow, gradual taper at their own pace. And there needs to be, the patients, it needs to come from the patient how they want to pursue that, with encouragement and support. And as we obviously know, someone who's been on for 20 years is not going to be able to come off in a kind of few weeks, and it would be very dangerous for them to do so. So it's getting out that information, because we are, I think, educating people that it's not ideal to be on these medications, but then that can read to some people as, okay, get people off as quickly as possible. And that isn't what we want to happen either. So I think it's explaining the situation, that it's kind of very nuanced. I think the other difficulty has been when you are not a medical person, which I'm not, and I have a great deal of respect for the medical profession, that you can be at times seen as kind of enthusiastic amateur. There's nothing wrong with being enthusiastic amateur, by the way, but all of us have such a great degree of technical information about this medication that I think can be better utilised, and maybe the medical profession, whether that be psychiatrists, pharmacists, whatever department, can see us as a resource to work alongside. So I'm working with the client, and I'm also working with these other, groups of specialities to get the best result for the person. And I sometimes feel that with all the debates that go on, and it gets kind of political on that then the needs of the person are lost. And all I want to do is achieve the best result for the individual as defined by them. It's not about kind of who's doing what. Obviously, I also started working last year at Dr. Mark Horowitz and Professor Joanna Moncrief, the deprescribing service in Nelft, which is only local at the moment, sadly. So please don't, write into Mark saying you'd like to use the service. And that's been a very interesting experience. And that is fabulous, because it's very joined up between the prescription and what I would be sort of advising or encouraging or exploring. But the way it's so disparate at the moment, I think is kind of the issue. I think if it could come together more, it'd be a bit more seamless and have more understanding. So I'd say that's the kind of biggest issues I would find. And also if we think about somebody's knowledge base, perhaps around a kind of problematic drinking or perhaps around a mental health problem, I'm sure it would still obviously get, you know, a lot of stigma and misconception. But I think if you said, what does it mean to be dependent on benzos? What does it mean to have to take a sleeping pill every night? Then I'm not sure we'd get a very accurate answer. So I still think, I don't know what it would take, but I still think there's a need to get more information out there. It's happening, but we're still up against quite a lot of misconception, I feel.
Okay, brilliant. Thank you, Melanie. Okay, so I think we're going to get to take some questions now. So I'll just open the Q&A box. I don't know if you're able to see this as well. No, sorry. Okay, so someone's asking, fantastic to hear that there are so many initiatives to assist people with phasing out. What I'm afraid of, the problems with tapering are treated in a different place from where they are prescribed. And don't we want prescribers to see how difficult it is to get off these drugs in the hope that they will become more cautious about prescribing? So I don't know which of you would like to chat about that.
Well, from our point of view, we do work directly with the GPs and the consultant psychiatrists, so we give advice, but the reducing regime is run through the GP surgery, so they are aware of the challenges that are facing the clients, and we do keep them updated, so they are part of that. And I think the more that we do some psychoeducation, maybe with the GPs, which we do in the surgeries, the more that we can support that change. I agree with what Melanie and Jayne have been saying, that it's a very slow process to get that idea out there and to turn things around. But I think things are happening, but there are always other drugs that are coming forward, like the Zopiclone and the Z drugs. So there's always seems to be something else that we are working on. But I think one thing that Melanie said, we have to keep these conversations open and keep them going. And I think that we are making a difference just by being there, which means it's all the sadder that we've got something like this happening with Jayne, and it feels like a real retrograde step for us. Yeah.
Okay, thank you. Yeah, so your service is quite integrated, isn't it? So I just wonder.
Yes, it is, but my background is in nursing, and some of the specialists that work within our team, so we've got a general nurse, we've got psychiatric nurses, and we've got counsellors. So yes, we're not the prescribers, but I think that's quite good. I mean, right at the beginning, I was offered the opportunity to become a prescriber, but I felt that would take away the ability to have that honest conversation with the clients, and not to be the prescriber, but to support and be part of that triad way of working with the client, the GP, and ourselves. Felt better.
Yeah. Okay. Okay, so another question. Somebody's asking, how do we get our GPs and psychiatrists to stop putting us on benzos? Anybody have any thoughts on that? Okay, I'll move to the next one. Someone's asking, June, how would someone apply for a role as a counsellor with your service?
Right, so how that currently works at the moment is we take CVs from counsellors that are working towards their diploma in counselling. So people send us CVs throughout the year. We take 2 intakes a year, and so we look at the CVs and we go through what we call HR Light, but we do interviews, select and train people from that point, so they get like a day's training from that. So it's basically an interview process twice a year that we go through to bring people in. So it's usually people that are working towards their 100 hours in counselling, although sometimes we do have some qualified counsellors who have decided they'd like to come and work with us.
We have something very similar actually as well, but it would mean, because now I'm with Change Grow Live, you would also be with the counselling project, so you would be working with people with other drugs. But if you'd come through REST, then I would obviously recommend that the clients be sent to you specifically, because I could give you some additional input on prescribed benzodiazepines.
Okay, I'm just going to have a look at the chat and see if there's any questions there that we should answer. Oh, I had a question actually about how you individualize reductions when you work with clients. So what kind of things you take into account? So I don't know which of you or all of you want to talk about that. Yeah.
Definitely the length of time someone's been on, how much they're taking, whatever else they're using, what their relationship is with the prescriber, and how they're feeling individually when they do try a drop. And basically very tailored and focused on what they themselves would find manageable and sustainable.
Okay, thanks. And Jayne, did you
Oh, sorry.
No, go.
I think for our service, because we dealt with more than sort of the benzodiazepine-based drugs, it'd be very much, again, like Melanie had said, it's client-centered. What is it that they're wanting to achieve? What is it you're wanting support with? I think it's important, again, to take a full history, how long people have been on these medications for, and for the reasons behind that. And the majority of clients that came to us were on more than one drug, sometimes up to 5. So it's looking at, dosages, how much they're on, what have they tried to come off before, which medication do they think is causing the most harm at this moment, which one do they want to start to come off, and then it begins to be an open dialogue into, well, maybe you could try this, or and then reviews are done at every single point in the reduction, and it's tailored to that person, and they might want to not completely come off of one drug, and hold on that's absolutely fine too. So it's very much led by the client and what it is they need and what support they need from us, and we will do that.
Okay, thank you. And June, did you want to say anything?
I think they pretty much covered it. I agree with everything that that both of them have just said. That's exactly what we do. We listen. We find out what they've tried before. It's how long they've been on it, but also it can be sometimes. We talked about the complexity of the drugs and what Jayne's doing. We do exactly the same around that. And we also consider the amount of the whole. So if somebody is, say, on 100 milligrams of a benzo, they might want to go down by a certain amount. But if they're only on 10, it's the amount of the whole that we look at as well. So it might be it's a lot less as they go down. So it's like little steps all the way down. So we've got rules of thumb, I think, that we all work with. But we also very much tailor that to the individual and listen. And like I said before, we're the client's advocate, which I think is important. And it might be that we don't deal with the medication first, that we maybe put some counselling in and make sure that somebody is in the right space. So it's about forming that relationship first before we start tackling the medication.
Okay, thank you. And could you also talk a bit about the kind of importance of your relationship with the clients when you're working with them? I can't remember who was saying that was so kind of, maintaining a good, just kind of keeping that kind of therapeutic relationship with clients.
Yeah, the therapeutic relationship is absolutely key. And recognizing what that person has come in for. You know, one of the things I smile about is the handbag syndrome. You know, somebody might have been sent to us because the GP wants them to come off of the medication. So sometimes that's not always easy for a client because they don't see it as a problem. So you've got to work on that relationship sometimes and tease away. So this is you and this is the medication. So sometimes that can be the issue. That they're not aware that there even is a problem. So there's that side of it as well. That so it's all around. I think Melanie or Jayne were talking about, you know, the psychoeducation and explaining how the drug affects the body, because not everybody is ready or wants to. So you have to look at what stage of change that somebody is in as well, because they might be coming for other reasons, and so you may be wanting to look at that first. So it's all gentle around the relationship, explaining, waiting for somebody to feel in the right place to maybe work on something like that.
Okay, thank you.
I think for us, the relationship is absolutely key, and because we don't have a cut-off time, you know, we don't help people up until the point that they've come off all their medication. It would be up until the point that they don't feel that they need us anymore, and that they're okay, and that can be years, particularly if you're talking about more than one medication. And you know, the access to support via the helpline, they can call every day. So if you take that, you know, and multiply it, that's a long time. So that develops into, you know, a very intense sometimes relationship, and you know, and that's how we support people all the way through until they're okay and are on their own. And also we because we support family and friends, we quite often get a call and they say, can you speak to my mum? You know, so then that develops as well, so everybody's on the same page, and we're helping, you know, not only the person who is struggling in their withdrawal and their tapering, but also their family systems and friends, so that they can then support and be educated as well.
Again, I'm going to mirror what the other two have said, because we've also got family and friends, so we have that same situation. We don't have a cut-off point. So some people are off, but they still come to support others, and they might come and do a talk with me. So I kind of know them in that capacity as well. So I've actually got people that I've known for 30 years. So that's an awfully long time. So yeah, I think the therapeutic alliance is absolutely key. And I think what I would see is maybe somebody trying to come along and convince me about how much they need the medication, how awful they feel, and they don't get it because they've had to try and convince people before who haven't really got it. But I actually do get it. So it's a case of building that trust for them to see that I'm in a very sort of patient advocacy role with them to a large extent. And I'm on board with most of how they're kind of seeing it. So unless they're doing something that's like really dangerous and have to put some harm reduction advice in, then I think they would see with their engagement with the project that I'm very much supporting their position. But yeah, that kind of relational aspect of it obviously had to be boundaried and professional, but I think that is absolutely crucial. And again, something that when we're putting in reports, Jayne and June, you know, it's hard to capture. I'm always happy for someone to come and see the group, although obviously some people might not want to be observed in that way. So I would let someone know we've got research that's interesting coming along. They may not want to attend that evening, but I think seeing the group in action is a lot more than I can put it over as I'm talking here.
Okay, thank you. And we have a few people asking about if you need to like live in the particular borough to access your services, or
for mine, yeah, Camden and Islington.
Yeah.
I'd love it to be more. When I work at an elf clinic, it's, you know, northeast London, but so no, we can't beyond that, unfortunately, at the moment.
I think that's the same for June, isn't it? It's North Wales.
It is, yeah. I work for Betsy Cadwallader University Health Board, so yes, yeah.
And then maybe one last question. What are the positives of your service. So what are the things you're most proud of about your services, or things like successes that you've had?
Well, I'm most proud of the people that have managed to taper and withdraw, or have an informed choice about whether to stay on or come off these drugs. The different committees I've been in, that's resulted into lots of nice guidelines. The BNF, as we said earlier, the different roundtables I've been on, the press that I've been into on to get the word out there. So, you know, consciousness raising. The supportive relationships in the group where people have maybe become friends outside of the group. And as Pat said earlier, seeing some of the volunteers come through and then go on to, you know, write a book or start some kind of movement. It's just unbelievable from such a small project. So kind of all of that and more, really.
Brilliant, thank you. And then June and Jayne, have you?
Yeah, I think that the success that I will take away now that the charity is closed is all the wonderful clients. They are absolutely amazing, to go through the struggle that they're going through, to keep on going day in, day out, tapering, and you know the difference it makes. You know, sometimes not all clients will phone back and say, oh, I'm better now. You know, sometimes they just disappear. But sometimes when people call back, it takes a minute for me to recognize who's calling, because they sound so different. They're well, you know, they're not crying anymore, they're not sad, they're not upset, they're not in complete despair, they're hopeful, and they've moved on with their lives. And I think that's what I take away from the work that I've done at Bristol Tranquilizer Project.
Thank you. And June?
Well, and yes, I emulate just the same. I mean, I've loved the support groups that we used to run and the people that came in, and watching the change and growth, and the individual work that we've done. And now that we've managed to grow it to a stage where I'm less involved with the day-to-day clients, but I can see that we have a model that helps people, because we have managed to go back to, I think in some ways, some old values where we take our time with people and we give people a chance, because in lots of the other areas it can be short term, whereas we don't do that. We work with clients until they get off, and if they need us for beyond that, again, we continue. So I'm proud that we've listened to everybody and put a service together that I believe works and is sustainable for people.
Okay, thank you. And actually one other question has come through, which is, do you see clients who are unable to work because their withdrawals are so severe? You know.
Most of my clients are unable to work, very sadly. Yes, yeah, I mean, that wouldn't be uncommon at all. It's a very tiny proportion of people I see that actually are in work. Some of them may have, you know, retired, but it usually is as a result of the tablets. Yeah.
I would definitely reiterate that most of our clients are not working, and because we do advocacy, and Melanie probably finds this as well, is that it's impossible, you know, more often than not, to get disability allowance or any kind of benefits, because the system is not in place to recognise drug dependency. So that is a real challenge, and probably another topic altogether. So yeah.
I think we found the same, that when people initially come to us, they may not have been working, or they've lost their interest in their art or their piano. But through slow work and supporting people to come off, we found that they do come back to life, and some people do go back to the jobs that they were doing. And that is really rewarding. And I think to see so many people, I found in this service that the amount of people that do improve when they do get the services that we offer, it is just staggering. And to see people going back to the things that they loved before they were on the medication, that they can go back to work, and they are, you know, have the confidence to do that, I think is just absolutely fabulous.
Okay, brilliant, thank you. Okay, so that's all we've got time for, but yeah, thank you so much, Jayne and Melanie. That's been really interesting and insightful, and yeah, thank you for taking the time to come and speak at this.
Thank you so much for
thank
having
you.
us. Be well, everyone. Bye for now.
Thank you.
Thank you.
Bye.